to the VORTRAN Medical Technologies training video for the VORTRAN Automatic Resuscitator, or as we call it, the VAR. Automatic ventilators offer several advantages over a bag valve mask, as you will see. This video will describe the VAR's basic controls, review the basic framework of proper ventilation, and introduce various tools which we can use to determine the efficacy of our efforts. While we may introduce accepted values, this video is not intended to define or prescribe any specific treatment for any individual patient. Now, let me give you a brief introduction to the VAR. The VAR has some very substantial advantages over the bag valve mask, and we'll go over those right now. First, you can see the VAR is plastic and entirely clear, so we can see if anything clogs the airway at any time. Here is the oxygen entrainment port. You're going to attach your oxygen supply here, and we generally use somewhere between 6 and 10 liters a minute of oxygen, which is quite a savings over the 15 liters a minute that we use in a bag valve mask. Next, we have this purple valve here, which is the pop-off valve. So should the pressure exceed 60 centimeters of water pressure within the airway circuit, this pop-off valve will open and dump the pressure, hopefully saving some barotrauma. Next, we have the ambient air entrainment port. If your patient has their own intrinsic respiratory rate and for some reason you lose your oxygen supply or run out of oxygen, your patient will be able to breathe in outside ambient air. This is your patient connection. You're going to put your tidal CO2 here, or you might connect it directly up to your ET tube. Moving down, we see the manometer. This is going to record the pressures in the airway at any point in time. It will also show you your peak inspiratory pressure and your peak and expiratory pressure. And that's an important feature of the VAR. The VAR ventilates with a peak and expiratory pressure, or peak pressure, of 1/5 of whatever the peak inspiratory pressure is. So it's a big advantage to ventilate your patients on PEEP as opposed to just ventilating them with a bag valve mask, and we'll go into the advantages of that later. Lastly is the patient modulator here. This is going to set your tidal volume, and it's going to set your respiratory rate. Now this is the round respiratory rate knob, and you can see right here it reads slower and faster. Well, the more I screw this knob in, the slower I will be able to expire air, and the slower I'm going to drop the pressures in the airway. And the more I screw this valve out, the faster I will be able to expire air, and the faster I will drop the pressures in the airway. And that's an important concept, and we'll go into that in a few minutes. The next valve here, it's shaped like a T. You can remember that because that is going to control your tidal volume, and the way it does that is this valve sets your peak inspiratory pressure. So the greater pressure you want in the airway, the more volume you're going to have to push into the lung. The more volume you push into the lung, the greater the tidal volume. So that's why we call that the tidal volume knob. It actually sets the peak inspiratory pressure, and as a result will also alter your tidal volume. So let me hook this up and I'll show you how this works. First, I'm going to take our oxygen supply tubing and I'm going to attach it to the green port. And then I'm going to take an end-tidal CO2 filter line and attach that to where my patient would be. And then I'll put a test lung on top of that. And now I'm going to turn it on to 10 liters a minute. Now you can see once the lung inflates, the manometer will start to read a pressure. When it reaches the preset peak inspiratory pressure right here, the valve will open and it'll allow you to exhale. Now this comes right out of the bag, set at about 25 centimeters of water pressure for a PIP. And you generally get a respiratory rate of about 20, but that's way too fast for us. So every time we hook the VAR up, and after the VAR starts to cycle, what we'll do is we'll take the round rate knob, screw it all the way in until respiration stops. And now we back the respiratory knob out just until respiration starts. and that leaves us with about 10 to 12 breaths a minute, which is right in line with what the AHA recommends for an intubated patient. As we start our discussion, let's not get the terms ventilation and respiration confused. For our purposes, ventilation is the act of moving gas in and out of the lungs. Respiration, on the other hand, refers to the actual exchange of oxygen and carbon dioxide that occurs at the cellular level of the alveoli. The act of respiration occurs through diffusion and is dependent on the partial pressure gradient and not ventilation. The objective of adequate ventilation is to move just enough gas with the proper mix of oxygen to meet the body's needs, and to remove just enough carbon dioxide so as not to disturb the acid-base balance. The function of ventilation is threefold. First, we need to expand the lungs by providing a large enough tidal volume, exposing enough surface area to allow the gas exchange to take place. The second is to deliver more oxygen than is currently in the bloodstream to create the partial pressure gradient necessary for diffusion. And third, to allow the proper amount of carbon dioxide buildup to be removed through passive exhalation. If any one of these three functions are not present, you will not have adequate ventilation. When used properly, pulse oximetry is highly accurate in determining the perfusing pulse rate and oxygen saturation, and is your best friend in a patient that is not breathing. All our intubated patients are unable to respond to us in the normal manner. However, if our intubated patient suddenly has an increase in pulse rate, it is a clear indication of increased stress, perhaps due to poor ventilation or discomfort stemming from poor sedation. In fact, hospitals use the pulse rate as the primary indication of stress for a fetus in vitro, so don't underestimate its use in your intubated patient. Pulse oximetry also indicates the real-time boundary of your safety zone in a non-breathing patient. Remember, a patient that is not breathing with a pulse ox of 98% is an emergency, but a patient that is not breathing with a pulse ox of 80% is a crisis. End-tidal CO2 monitoring allows us to see in real time the effects of each breath we give to our patient, and is an early indicator of respiratory status changes to come. It is important that we begin CO2 monitoring as soon as possible, even before intubation, through non-invasive cannula monitoring. These cannula readings can be a confirming tool to support your initial diagnosis and establish a baseline for the patient. Being complacent and just accepting the established norm of 35 to 45 millimeters of mercury may not be the best thing for your patient, as those are just calculated values and not based on any metabolic need. Thinking in the big picture, it all comes down to allowing the body to attain and maintain the proper pH. These are the elements that the body uses in the respiratory system to balance the pH. How you ventilate either helps or hinders this process. You control CO2 values when you ventilate, a primary compound affecting pH, but you have no idea what the current pH of the body is, high or low. However, the patient's body does. While ventilating, among other things, you are responsible for maintaining a consistent value of exhaled carbon dioxide, and given that stable target, the patient's body will be able to do its part and make its own adjustments to balance the pH. Let's review some terms you should be comfortable with before moving forward. PIP stands for peak inspiratory pressure, and on the VAR is set by the T knob as shown earlier. PEEP stands for peak end expiratory pressure and is set automatically by the VAR to be 20% of whatever you set the PIP to be. Minute volume is the total volume of gas being moved in or out of the lungs every minute. I time is the time it takes you to fill the lungs, which is controlled by the liter flow set at the oxygen source and the PIP setting. E time is the amount of time it takes you to exhale your breath, and on the VAR is controlled by the round rate knob. Proper ventilation is very complicated and there is no way to simplify it. To begin, start with our guidelines and adjust your settings to suit the particular patient. Remember, while our guidelines tell us to ventilate at 8 to 10 breaths per minute with a pulse ox of 95% and an end tidal CO2 of 40, your patient may require a different set of values. Let's look at one common scenario. You arrive on the scene to find a known diabetic to be unconscious in DKA with Kussmaul respiration. The patient has a pulse ox of 98%, breathing at 40 times per minute, and your nasal filter line tells you his end tidal CO2 is 20. The problem here is that while we know the body can and does use the respiratory system to blow off CO2 to compensate for metabolic or ketoacidosis, we have no way of confirming that is the case here because we have no instrument to measure the blood pH. We do know, however, that when we slow down the patient's respiratory rate from 40 to the recommended 8 to 10 breaths per minute, the minute volume will decrease and your end tidal CO2 will begin to rise and your blood pH will begin to fall. That might be a good thing or a very, very bad thing. You just have no way of knowing. What is the answer? First, make sure the patient has oxygen. Then, because you are blind to the other half of the ventilation equation, which is the pH balance, look at the other clinical signs and use your clinical judgment to establish a set of respiratory values for the body to adjust to and use the VAR's consistency to maintain them. When manually bagging a patient, you are unable to maintain a consistent minute volume, so you create a randomly moving set of values that the body has to constantly chase, causing our already compromised patient to deal with even more stress. Okay, now bearing all this in mind, how do we operate the ventilator, and specifically our brand, the VAR? First thing is to realize there are 3 safety mechanisms designed into the VAR that we don't find in a bag valve mask. The first is the pop-off valve that we showed you earlier. The second is built into the VAR's design and prevents an incomplete exhalation, or stacking breaths, which often happens when we excitedly bag a patient too fast. And third, the VAR maintains a peak end expiratory pressure, or PEEP. The design of the VAR allows you to ventilate with PEEP safely because it will not cycle another breath until you have exhaled enough gas, dropping the airway pressure to the pre-designed PEEP. Even a reverse IE ratio can be tolerated for the relatively short time we are transporting patients. Should you doubt the benefits of PEEP, take a moment and watch this video to see the benefits as they turn PEEP on and off. Now we have 3 controls on the VAR. First is your oxygen supply. We initially set that at 10 liters a minute. Second is the peak inspiratory pressure using the T-shaped knob, which also determines your tidal volume. And third is the round rate knob. The VAR works by filling the patient's lungs with oxygen and expanding the lung walls until the desired inspiratory pressure, or PIP, you set on the T-shaped knob is reached. At that time, a diaphragm opens, allowing exhalation, which also reduces airway pressure at the rate that you set using the round rate knob. Once the airway pressure drops by 80%, then the diaphragm closes again to begin the cycle over. The oxygen inlet controls how fast your patient receives oxygen. The faster the liter flow, the faster you will fill the lungs, and the converse is true. This is one of the factors that determines your I time, or inspiratory time. For example, we usually set the VAR at 10 liters a minute. If we only have 2 seconds before the diaphragm opens, allowing the patient to exhale, I have a 2-second I time. And at 10 liters a minute, That represents 333 milliliters of oxygen. My tidal volume would then be 333 milliliters of oxygen. The T-knob controls the peak inspiratory pressure, or PIP. The greater the pressure you set, the longer it will take your incoming liter flow to build up to that pressure, and the greater the tidal volume will be. As well, the converse is true. Hence, while the T-knob actually sets the peak inspiratory pressure, we call it the T-knob because it also controls our tidal volume. Lastly, the round rate knob acts as an expiratory resistor, controlling the rate at which the airway pressure drops and, as a result, the time where the diaphragm will close and allow the lungs to fill again, thus repeating the cycle. You can see by controlling how fast or slow we exhale, we can adjust the overall respiratory rate. Screwing the round rate knob either in or out does just that. The benefits of the VAR are numerous. The most notable ones are that it is lightweight, it uses less oxygen than the BVM, it automates ventilation, freeing up personnel, it eliminates extraneous personnel in a crowded workspace of the back of the ambulance, maintains consistent end-tidal CO2 and oxygen saturation, and reduces the chance of tube displacement during patient movement. The VAR comes pre-assembled, and there are just a few simple steps to remember in order to apply it correctly. First, squeeze the VAR together to tighten any joints that may have worked loose during storage. Second, connect it to an oxygen supply and set it at 10 liters a minute. Occlude the patient outlet to make sure you hear it cycling. And last, attach the VAR to the patient and set the respiratory rate by screwing down the round rate knob and then back it out just until you hear cycling begin. That's all there is to it.
Bar is tight. Alright, disconnect the bag valve mask oxygen and turn it down to 10 liters a minute. VAR. We'll test for cycling. Is. Get ready, we'll move the bag. Okay. Tighten the VAR all the way. And then loosen until we begin cycling. There we go. Cycling, we have good chest rise. Secure the bar to the collar. Secure. And let's get the scoop stretcher and we'll go back.
Okay, we'll measure this out for size.
Okay, you have good bilateral breath sounds, no epigastric sounds. How's our liter flow?
Okay, our liter flow is at 10 a minute and we're at 1,000 psi, so we're good.
All right. Ready? Ready? 1, 2, 3. Good bilateral brush sounds, no epigastric sounds.
Sounds good.
Let's get going.